Good evening, everybody. My name is Oreste Gentilini. I'm a breast surgeon from the San Raffaele Hospital in Milano, Italy, and also vice chairman of UBreast, European Breast Cancer Research Association of Surgical Trialists. And welcome to this webinar of UBreast, which is the first one of a series of 6 that will take place in 2021, approximately every 2 months. Basically with more or less the same template, the same format. So just one question, just one issue with a very limited number of experts trying to address this issue, possibly from different perspectives and angles. The meeting will be of 1 hour maximum in duration. So we are supposed to close this meeting at 7 p.m. The title of the webinar of today, I think it's very interesting because it's the impact of biology on breast cancer surgery. And so I'm sure that we will have many questions arising, and actually do not be shy, please. And you're actually encouraged to ask questions at any time by using the question and answer option that you can find at the bottom bar of your screen. So please ask questions at any time, and the moderators will be pleased to take your questions and to forward to the speakers of today, who actually are 2 outstanding experts and speakers. So it's my pleasure to introduce the 2 speakers of today. Actually, they basically do not need any introduction because everybody knows them, but still we have Giuseppe Curigliano, medical oncologist from the European Institute of Oncology and University of Milano, Italy, and Peter Dubsky, surgical oncologist from Sant'Anna Breast Center in Lucerne, Switzerland, and University of Vienna. And I would like to thank both Peter and Giuseppe for joining us and for their contribution. We would like to thank Myriad Genetics and Polytech for their unconditioning support. And also we would like to thank the people who's actually working behind all of this. So Giulia Azzi and Mauro Dompe for technical support, and Sarah Goldman for acting as UBreast network coordinator. So now I would like to also introduce Thorsten Kuhn from Esslingen, Germany, and actually, by the way, chairman of UBreast. So Thorsten, please.
Yeah, warm welcome to everyone, one from my side, and thank you, Oreste, for the kind introduction. We want to start right away, and before starting the presentations, I want to invite you to participate in a voting. And Julia, would you please present the vote? So the question is, do you currently use short-term 2 to 3 weeks endocrine treatment prior to upfront surgery in early ER-positive, HER2-negative breast cancer patients? Yes or no? You have 15 seconds to reply, and please give your response now.
We have 10 more seconds.
We cannot vote, I see.
No, we can't.
5 more seconds. Okay, I think we can end questions now. Do you want me to go?
Yes, please. Okay.
Okay, this is interesting, but I think that it is something that is weighted, that is not unusual, because the preoperative endocrine treatment is not yet established in most guidelines. So we want to start right away with our presentations, and Oreste already introduced Giuseppe Curigliano from Milano. He's a real expert on medical oncology. As Oreste said, that we want to discuss the impact of tumor biology from the view of a surgeon and from the view of medical oncology. So Giuseppe will start, and Giuseppe, we are very much looking forward to your presentation.
So thanks a lot for the kind invitation. I like very much to be here with friends and to discuss about the impact of biology on breast cancer surgery. So those are my disclosures. So what determines local control and how do you select, of course, patients for surgery? I believe the most important point is the disease burden. That's why you call me every time when you need to perform a neoadjuvant treatment in order to reduce the tumor burden and to guarantee a better local control. But we know very well that the selection of criteria for breast cancer treatment and specifically for breast cancer surgery can be biologically, and so histology, grade, nodal status, ER status, HER2 status, and potentially also gene arrays. I will present to you some data recently introduced during the meeting at San Antonio. And some others are also mechanical: extent of disease in breast, negative margins, diffuse calcification, multicentricity, ability to give radiation therapy, prior radiotherapy, or any other type of autoimmune disease. So what's about subtype and recurrence of breast conservative surgery? Of course, we need to understand also the history of the biology that can impact on the type of surgery. Those are very old data published in the, let's say, last century finally. But in any case, it's quite clear that if we analyze the biology of the disease, according not to molecular subtype, but according to ER, PGR, and their HER2 status, it's quite clear that if you have an HER2 positive disease or a triple negative disease, you may have a higher rate of local recurrence. So I believe this is a very important information. And finally, also in the context of subtype and recurrence after mastectomy is exactly the same. Spatial biology of cancer, HER2 positive or basal-like, may predict a higher risk of local recurrence. If we look also at PT1-MYC, PT1A, or PT1B breast cancer, so when we analyze biological features of disease like ER positivity, HER2 positivity, or triple negative disease, you can see here that for luminal A and luminal B, also with these bold tumors, you have less risk of relapse. And you have higher risk for luminal B HER2 positive, for triple negative disease, and for HER2 positive, which is the risk of local recurrence by molecular subtype. So in this case, we are moving to the PAM50 characterization of disease. And here it's quite clear that we have a lower risk for luminal A and luminal B, and an increased risk for triple negative disease and HER2 positive disease. Does effective systemic therapy contribute to local control? Yes, absolutely yes. If you deliver chemotherapy or tamoxifen in the context of NSABP B13 or B14, you have less risk of local relapse. And this is exactly the same when you use Herceptin in HER2 positive disease. So I believe this is a very important information. This is a real-world study in which has been assessed the effect of trastuzumab on local control. Here we have patients with T1, T2, and 0 HER2 positive breast cancer that received breast conservative surgery plus radiation therapy. Some of them have been treated with trastuzumab, some others without trastuzumab, and the risk of locoregional recurrence is 7% in patients who received no trastuzumab, and 1% in patients who received trastuzumab. What's for triple negative disease? According to stage 1 and stage 2, we have exactly no effect about the type of surgery, because even if you perform a breast conservative surgery or a mastectomy, finally, the probability of locoregional recurrence-free survival is exactly the same. So which is the impact of biology on breast cancer surgery? First, the locoregional outcomes can be different by molecular subtype. Bigger surgery does not overcome bad biology. Effective systemic therapy decreases the risk of locoregional disease, and increasingly effective multimodality therapy offers the chance to decrease surgical morbidity. The local control, of course, is different according to molecular subtype. And the bigger surgery does not improve outcome for high risk. So I mean triple negative or HER2 positive disease. Can we use a response to neoadjuvant treatment to make a better decision in breast cancer surgery and systemic therapy? And I would like to mention this beautiful study that has been presented during San Antonio meeting 1 month ago. This is the final analysis, of course, of the ADAPT HR positive HER2 negative trial, in which patients with 0 to 3 lymph node and the recurrence score less than 26 have been treated with endocrine therapy alone or with chemotherapy, according to the activity of a window of opportunity using endocrine therapy for 3-4 weeks before surgery. So in Lumina yearly breast cancer, the optimal patient selection for remission of adjuvant chemotherapy is finally unclear. We know the data of their responder, of course, but when the ADAPT trial was designed, this was not clear. And the omission of chemotherapy in any case seems to be safe in PN0 with the recurrence scores less than 25, according to Taylor-Ricks, or PN0 and 1 with the MAMA print low risk. So finally, the trial assessed the dynamic Ki67 response to a short preoperative endocrine therapy. This was the question that we addressed before starting the symposium. And looking at the POETIC trial, it seems that dynamic Ki67 response is associated usually to a favorable patient outcome. And this is the design of the study. We have female patients more than 18 years old, ER-PGR positive, HER2 negative, a stage between CT1 and CT4C, with CN0, CN3, candidate for adjuvant chemotherapy by conventional prognostic criteria. So those patients finally have been assessed for recurrence score and received a preoperative endocrine therapy for 3-4 weeks before doing surgery or biopsy. So for patients with a recurrence score more than 25 or a Ki67 plus following endocrine therapy more than 10%, patients received the neoadjuvant chemotherapy and then, of course, surgery. For patients with N1 and 0 and the recurrence score between 12 and 25, intermediate, or less than 12, and of course, a Ki67 post neoadjuvant endocrine therapy of less than 10%, they received endocrine therapy alone. So it's a very provocative study, I believe. So you can understand that those patients may be also with a recurrence score between 12 and 25, and also with nodal involvement, but they received just endocrine therapy because they had a response to the preoperative endocrine therapy. So the primary endpoint was the 5-year invasive disease-free survival, and the secondary endpoint was the distant disease-free survival. And the trial design was a non-inferiority trial. Those are the patients that have been allocated. So we have finally something like 2,356 patients that have been allocated to endocrine therapy alone. And they had a recurrence score between 0-11 or between 12 and 25, and the Ki67 of less than 10% post-neoadjuvant endocrine therapy. So 868 patients had a recurrence score of 0-11, and 1,422 a recurrence score between 12 and 25, and the Ki67 after neoadjuvant endocrine therapy of less than 10%. So those are the endocrine response in the run-in phase. So it's quite interesting to understand that, of course, the majority of the patients with a recurrence score 0-11 had finally a Ki67 response, but also 76% of patients with a recurrence score between 12 and 25 had finally a response after neoadjuvant endocrine therapy. And here we have different stratification factor, including N0, and of course also N1 and 3 patients. This was the median age, 57 age for R0 and 11, and 58 age for recurrence score 12-25 with a Ki67 of less than 10%. 34% or 38 with PT2 at PT4, PN1 status in 24% in the PN0 and 1, and 27% in the population with intermediate recurrence score and Ki67 less than 10%. So look at the data. So the primary endpoint that was 5-year invasive disease-free survival, if you receive endocrine therapy alone, according to this selection, so I am discussing about recurrence score 0-11 or recurrence score 12-25 and endocrine responsive, there is absolutely no difference of invasive disease-free survival. So 93.9% invasive disease-free survival for low recurrence score and 92.6% for recurrence score between 12 and 25, receiving a neoadjuvant or a window of opportunity endocrine therapy for 3 to 5 weeks. So this is really outstanding in my opinion. Look at the distant disease-free survival. This is much more impressive. There is absolutely no difference in terms of distant disease-free survival and overall survival. You can, of course, tell me that we have a very short follow-up. Maybe this is true for this patient population. We need a longer follow-up in order to understand if this data will be confirmed. But looking at the data, an overall survival of 98% for low recurrence score that is expected, but a 97.3% in the intermediate recurrence score and endocrine therapy responders is not so obvious. So this is the distant disease-free survival in age less than 50. So we suppose here we have a lot of patients that are premenopausal, and in age more than 50. And also here we have an excellent outcome selecting the patient by response or Ki67 response after a short preoperative endocrine therapy. And those are the data for non-negative and 1 to 3 positive nodes. Don't forget that in the responder here, the outcome is completely different for the same patient population with the recurrence score between 12 and 25, at least for premenopausal. This is the uni and multivariate analysis, and it's quite common that we have a non-inferiority between the two arms. And here we have the distant disease-free survival according to involved nodes. Finally, of course, for patients that are lymph node 3, PN3, of course, we have a different outcome, but for 1 and 2, we have exactly the same outcome. So the primary endpoint was reached. Patients with luminal early breast cancer in 0-3 lymph nodes and the recurrence score between 12 and 25, and the endocrine response after short preoperative endocrine therapy have a 5-year invasive disease-free survival that is exactly the same to those with 0-3 node and the recurrence score 0-11. The outcome was excellent in both groups. Also in terms of 5-year distant disease-free survival and overall survival. The outcome was similar in both groups irrespective of age. And the subgroup analysis, of course, suggests that among patients with a recurrence score between 12 and 25, those with 3 or more involved lymph node may not be ideal candidates for endocrine therapy alone. And this is finally the conclusion. Oncotype DX testing can spare chemotherapy in the majority of patients. Dynamic Ki67 response testing is feasible and can select a subpopulation of patients in which can be omitted chemotherapy, and so you can perform surgery. And this ADAPT trial is currently evaluating an endocrine-based approach in patients who are not candidates for adjuvant endocrine therapy alone, comparing CDK4/6 inhibitors versus chemotherapy in the adjuvant setting. So which is the impact of biology on breast cancer surgery? This is not only related to disease burden, but according to this trial seems to be related also to therapy, a short preoperative course of endocrine therapy, and of course to biology. Biology that has been explained by ER, PGR expression or HER2 negativity, but also according to a gene array like Oncotype DX. So thanks a lot, and we are ready now for questions, if any, or we move to the next presentation.
Okay, thank you very much, Giuseppe, for this really excellent presentation of fascinating new data. We said that we might have one urgent question, and I had one check from Michael Unsch. We normally had decided to mute the micros, but I think if Michael Unsch asked for a question, we could not omit this. So my question to Julia, could we unmute Michael?
Yes, I am looking to the question.
Yes, so,
yes, because it's a very
Michael, welcome.
So, you know, Michael, you can comment first, please. Yeah. Go ahead. Yes.
Thank you again. And well, actually, I gave already the question in the chat because it was not planned to have an audio question. So very short. Excellent presentation in San Antonio to the topic of multi-gene assays and the dynamic score for Ki-67. Now, one, as you have seen, and I think this is probably not just a gut feeling, but most of us were not ready for prime time for dynamic Ki-67 for a therapeutic decision in hormone receptor positive patients. Now, my question is the following. In RxPonder, there were quite large number of patients in the group of 1 to 3 positive lymph nodes, who even in the lowest recurrence score risk group, 0 to 10, premenopausal, not postmenopausal, premenopausal, who have a significant, in my eyes, and if you have the question, is their opinion too, a significant benefit from chemotherapy. So question number one, why to do a multi-gene assay in premenopausal patient with 1 to 3 lymph nodes, seeing that even those patients who have a very low recurrence risk still have a significant benefit from chemotherapy. And what I am really missing in all these studies, there was no Ki-67 implemented, Giuseppe, which is all the clinical work in your tumor board, in Davide's tumor board, in Thorsten Kühn's tumor board, in Peter Tupsky tumor board, in all the world. So these data were not shown. And linked to this question is also, I call it a critical view on ADAPT. In ADAPT, very nice hypothesis. It is not a randomized trial comparing or to the question of the dynamic of Ki-67 going down. Because if you see the groups of 1, 2, 3 lymph nodes and you split it by premenopause, then you have subgroups of really 1 to maximum 2 digits in these subgroups. So I cannot at this moment rely on the dynamic of Ki-67 in these patients to tell them, premenopausal, to tell them you are fine, you go down with Ki-67, you don't have a high risk, I just give an endocrine therapy. I do not feel secure enough. Thank you.
So you just to answer to your point is a good point, of course. This is a non-inferiority trial as a statistical design. When the trial was designed, there was no data related to their responder. So, you know, it's a very provocative study, I believe. That's why together with Peter, we decided to present it, because you can reach, let's say, a small subgroup of patients that are responsive to neoendocrine therapy for a window of opportunity with an intermediate recurrence score that in any case have a very good outcome. I agree with you that the patient sample size is underpowered to demonstrate this. But are you sure that in the responder you can give just ovarian suppression and endocrine therapy, and maybe you will have exactly the same benefit? Because in a responder, 70% of patients did not receive ovarian suppression, even if premenopausal. You know, we just presented this to be provocative. Maybe in clinical practice, I would prefer to have Oncotype DX between 1 and 3 in after surgery, and I will not select according to dynamic Ki67. So this is my personal opinion. But I believe it's nice to present this data. This was an innovative trial, and finally the results are very provocative.
Hey, Michael, I think your comments are really well taken. And I don't think anyone in this forum is suggesting that this is prime time. But you know what I really like? I like this practical approach of combining a gene expression assay that is maybe not very good in node-positive women, right? And combining this static feature with a dynamic feature of Ki67. And I think what Nadia Harbeck is really trying to suggest is that there are about a quarter of women that did not respond to that short pre-op endocrine treatment. And when you sort those out and give those chemotherapy, then in fact, you end up with a bunch of women that maybe truly don't need chemotherapy. But again, you're right. This is not prime time, but I think it's really strong hypothesis generating. And I think what we need to do in the future is create larger trials along that line using premenopausal women. I think those would be wonderful studies. Personally, I think, you know, there are a lot of practical things going on with women that have a breast cancer diagnosis. They need staging, they need to undergo the tumor board discussion. Right now with the pandemic, scheduling surgery is not that easy. So personally, I have actually given some of my patients short pre-op endocrine therapies simply because I couldn't schedule them right away anyway. And I think that is an additional factor that can help me make a better decision. That's all I'm saying. So for practical terms, sometimes you can do this. And I think hypothesis generating for future trials, yes.
Okay,
Thank you.
Thank you very much, Giuseppe. Thank you, Michael, for your very, very interesting question. And thank also to Peter for commenting on this. And actually now Peter, it's your turn to give your perspective about this issue. So Peter, please.
All right, let me just pull up the slides all the way here. So hello from my side. This is Peter Dubsky speaking. I'm actually a surgeon, and Giuseppe Curigliano is just an honorary surgeon, okay? He just gives very good talks. This is a UBreast webinar. Obviously, we want to meet you face-to-face again soon, but this is all we can do for the moment. But guys, great job, really. Let me just see if I can move my own slides. Here we go. I do actually have a relevant disclosure down here. I did a lot of validation work for the EndoPredict test via the Austrian Breast Cancer Study Group. And it's noted on this slide, it's the company Myriad. So I'm going to be talking about that too. Simply because you can't see everyone and we can't meet, this is a picture of the entire team in Lucerne, just to let you know that we miss you very much and we hope to see you soon. The data that I'm going to talk about has actually been published in the European Journal of Cancer late this summer. You can read up on it. It's a very good journal. Giuseppe can maybe open it for everyone to download. What I'm really going to talk about, let me just get this down here. What I'm actually going to talk about is trying to use gene expression assays to make better surgical decisions. And I think what Giuseppe already pointed out, you know, we have the clinical and the prognostic factors, and maybe some of you are actually using algorithms made of these, such as Adjuvant Online, which actually is being updated as we speak, the NHS Predict or the CTS from the Brits. And then we have these really popular gene expression assays, such as the MammaPrint and the Oncotype, which have large prospective trials. And we have the newer tests that don't have a lot of prospective data on them. And one of them is EndoPredict, but the other one you may know is Prosigna or the Breast Cancer Index. Now, coming back to the EndoPredict trial, this is the EndoPredict test has been validated in a number of very large prospective trials. These are always retrospective analyses of prospective data sets. Two are from the Austrian Breast Cancer Study Group, and this is work that I was involved in a long time ago and even reaching to today. And I think what you can see and what this test really does beautifully is that in ER positive, HER2 negative patients with 0 to 3 positive lymph nodes, you have a very clear differentiation to low and high risk. And importantly, you can see the low risk, even at the point estimates around 10 years, are well below 10% in terms of distant recurrence-free survival. So these are patients identified that have very, very good prognosis. And also, if you check out the numbers, it's really a very high percentage of patients that can actually be categorized into low risk. And I think that can easily forgo chemotherapy. So just talking about the node positives once more, within these study cohorts, we actually gathered all the node positives. And you can see that even in the 1 to 3 positive lymph nodes, there is at least a third or maybe 20% in the Transitac cohort that still have a low risk or can be identified as very low risk. So EndoPredict's very similar to some of the data we've seen with NanoString, some of the data we've seen with Oncotype, is able to identify patients with low risk in node positive, ER positive disease. Just one more thing about EndoPredict in particular, it's a very good test, especially for late distant recurrence. Oops, let's go back one. You can see that even after 15 years, this test is still valid in patients that have been free of metastasis until year 5, graph on the right-hand side. And again, it's actually quite a large portion of patients that have late, low risk in distant recurrence. Now, one of the things in these studies that we have done is really trying to learn from genes and trying to make assumptions about biology. And if you look at this data here, and what we've actually done is we've looked at the genes that are functionally active in proliferation and the genes that are very much into ER signaling or are involved in the differentiation of the tumor cell. And you can see that the genes have a different impact in looking at recurrence in years 0 to 5 and years above 5 years, so there's years 5 to 15. So learning from these experience was really, could we use this test to predict response to chemotherapy or predict response to endocrine therapy, given that the genes involved say a lot about proliferation or ER signaling? So we had the chance to do this in a prospective way in the ABCSG34 trial. The ABCSG34 trial was a very strange trial, but let me go through it very quickly. It's a 400-patient randomized phase 2 trial. And it was not the test, it was the clinicians that chose the patient either for this neochemotherapy arm up here, which had about 300 patients, and those patients had 6 months of standard chemotherapy, or the patients could be chosen for a neoendocrine arm, obviously based on estrogen receptor grading and Loki67. So basically they chose the luminal A's for this arm and the luminal B's and the triple negatives in this arm. And actually the outcome of this trial was testing an immunotherapy called Tisemotide, which is a MUC1-based vaccine. To make long story short, the MUC1-based vaccine did not work. So we did not have an impact of this factor here, which gave us a great opportunity to do translational research in the neochemo arm and in the neoletrozole arm. And that's exactly what we did. So in the biobank, we were able to identify 217 women that had ER-positive, HER2-negative disease and were within this multi-center ABCSG34 trial. They received either neoadjuvant chemotherapy or neoadjuvant endocrine therapy. Again, importantly, keep in mind, they were not chosen based on the EndoPredict test. We applied the EndoPredict test without letting the patients or the investigators know. The primary endpoint of the trial was not PCR, it was actually residual cancer burden. I think you're probably aware of it. Residual burden curve 0 is basically a pathologic complete response. RCB1 has very, very similar outcome and is minimal residual disease. And then you have poor response patients that are the 2 and 3s. So we'll be using this as an outcome also for the translational study. Now, having said that the clinicians chose them, this is easily seen in the demographics. You can see the neo-chemo group. These are patients with larger tumors, with very high Ki-67, with a higher percentage of G3 tumors. And of course, they responded well to chemotherapy with all over 25% RCB 0 and 1. And you have a smaller neoendocrine group. And of course, these are typically luminal A patients. So the Ki-67 is much lower in these patients, very uniformly low, in fact. And there are almost no G3 patients in the neoendocrine group. Now, let me show you the data. This is the neo-chemotherapy group, so over 100 patients. And if you look on the scatter plot on the left side, what is really astounding is that patients with a low EndoPredict score, so these are the EP lows, really did not respond to chemotherapy properly. You can see that there are absolutely no women that had a low prognostic score, that had a good chemotherapy response. So basically what this gives you is a negative predictive value of 100%. Positive predictive value, so actually identifying patients that do respond, is not great. They are certainly increased in that group, but I think what is really valid in order to make a better surgical decision, a patient with an EP low score is extremely unlikely to have very good tumor shrinkage. I think this is what this really says. Now, in the neoendocrine group, you have the opposite effect. It's not as clear here, but again, look at the scatter plot on the left side, which really shows you. You can see that in patients that have a high EP low score, you do not have a good response to neoendocrine therapy. You can see, again, the negative predictive value is above 92%, in fact. So this really shows you that if a patient has a high EP, this should be a patient that receives chemotherapy and not neoendocrine therapy. I think one of the things that I'd also like to point out, maybe going just back one slide again, keep in mind, these patients were chosen by clinicians to have chemotherapy. And despite this clinical judgment, you have quite a large percentage of patients that actually have low molecular scores. So in retrospect, you could have said, probably these patients shouldn't have had chemotherapy in the first place. These are, again, the predictive values showing pretty much powered on the negative predictive values that this is valid. Just to summarize this a little bit for you, what we've really seen is that the molecular score per se is able to predict non-response, so it's a negative predictive value, both to neoadjuvant chemotherapy and endocrine therapy in the small subset. It is very much driven by the high negative predictive values. So you are able to identify patients that are very unlikely to respond. And especially if you're a surgeon and you're thinking of breast conservation and you're trying to make a point, I think this can be helpful in your clinic when you go back tomorrow and Friday. Just to make you aware, using gene expression to predict response has been endorsed by a large consensus called the Lucerne Toolbox. It has just been published, and the link that I provide here is the personalized share link. So if you click this link, you can download this paper from Lancet Oncology. Giuseppe doesn't have to do it because he's a co-author. So thank you very much. This is just a short presentation. I'd like to point out, people think that gene expression is just good for making adjuvant decisions. And I'd like to point out that not only the VSG and Nadia Habeck is using this in the neoadjuvant decision-making, but for example, the I-SPY trial people have been using MammaPrint to rule out low MammaPrint patients from their neoadjuvant chemotherapy trials. And a lot of study groups are selecting their patients using gene expression tests as we speak. So thanks a lot. And I'm not sure whether we have any questions.
Okay, thank you, Peter, very much for this really excellent presentation. We have a few questions, and I would like to ask our participant to just put your questions into the chat. First of all, we have a question from Annette Lebeau, who's a pathologist from Hamburg, member of the German Guideline Committee. And first of all, Peter, she congratulates to your really outstanding presentation. Another question that she has is, do you have Ki-67 data for your study upfront?
So if the question is, yes, we do have the Ki-67, and we compared it in the univariate and multivariate model to the gene expression. And it's interesting, in the neoadjuvant chemotherapy, where you have a large variation of Ki-67 patients, so it was all over, you know, you had patients with 15 and you had patients with 60% of Ki-67. The Ki-67, together with the proliferation module of the test, is a very significant factor. The models are not big enough or not powered enough to actually tell you whether this information from the molecular score is truly complementary or if there's a strong overlap with the Ki-67, but there seems to be a complementary information here. In the neoendocrine group, it's really different because there's a very homogeneous thing with the Ki-67. So the Ki-67 did not seem to be an important factor for predicting neoendocrine response. But I think that is simply a statistical thing because the variation was not high enough in the group to show that.
Okay, thank you, Peter. So there is another question by Michael. Now, my question is, Michael, do you want to put it in the chat? It's a little bit unfair not to let Annette speak.
No,
you speak. So
Annette can always speak because I work with her for 15 years together at the University of München. So my personal, let's say, preference to ask by audio should not defer her from asking by audio. So I give her the second chance if she likes to comment this question.
So, I think my proposal is, so we unmuted everybody because we did not know how many proposals we would have. So there are not too many contributions. So I propose, Julia, if we could unmute somebody with a question. So this would be equal conditions for everyone.
Yeah.
So Michael, your question.
And preferentially women. There's too many men talking here.
Yes, absolutely.
We're a manor.
Annette, okay. Annette, we will unmute you for another question. Annette says she's okay.
Okay. Okay, Peter. I mean, in my clinic, I'm in a minority because we have a purely female team, as you know. Anyhow, can I ask my question? Okay, good. So it goes into the same direction as Annette Lebeau asked it, because we know all multi-gene assays are, as you already mentioned, driven by, preferentially Ki-67 and the estrogen receptor signal. Now, it has been, I mean, very obvious that the response to neoadjuvant therapy is very much linked also to the multi-gene assays. So it's a nice tool to play with. But what is the consequence if a patient, let's say, who has enough clinical risk factors to receive adjuvant or neoadjuvant chemotherapy, like, multiple lymph nodes involved, blah, blah. What does it bring to me or to the patient to do a neoadjuvant therapy, to do a multi-gene assay, and then to say, oh, if the if the multi-gene assay is not showing a response, I will not do the neoadjuvant therapy, I go straight forward to the surgery, fine, but you're not going to spare these patients from adjuvant chemotherapy. So what is in fact I mean, again, I very much like this intellectual tool to play with, like it has been done in ADAPT, like I'm doing since 35 years neoadjuvant therapy. So I know all these approaches since many times. So just tell me what it is new about it. What should I do tomorrow on Friday or maybe next Monday, changing from San Antonio, changing from your very nice data, which I look forward to read the full paper. Thank you.
So the first answer is we shouldn't have unmuted Michael because he has good questions. But so Michael, I think the data is valid because there is a big difference in the life of a patient, whether she gets adjuvant or neoadjuvant chemotherapy. And if truly she has a tumor that is very unlikely to respond in terms of tumor shrinkage, then giving her neoadjuvant chemotherapy is not going to save her breast. It's not going to save her axilla. And you may as well go for surgery and have adjuvant chemotherapy. And that can be an important factor in the organizational life of a woman. So I think that is relevant. But I'd like to point out, I am absolutely not saying that with EP low, I am sure the patient doesn't need chemotherapy. What the study shows is that I don't have good tumor shrinkage, which, as we know, in ER-positive disease is not the same thing as survival outcome. I think we need to be very careful here. So I think what Nadia Habeck and the WSG group is really doing is they are aggressively de-escalating chemotherapy from node-positive women. I'm not de-escalating. I'm just trying to make better choices between adjuvant and neoadjuvant therapies.
Peter, may I ask a question? I think we are a community of surgeons. And so the issue is, what is the consequence for our surgical treatment? I think you would agree that if we have a locally advanced tumor, it's luminal A type, and we think that this tumor does not respond to chemotherapy, or does not much respond to chemotherapy, would all probably as surgeons rather go for oncoplastic surgery than for neoadjuvant. So my question is, if you have a tumor that is luminal A from hormone receptor status, grading, Ki67, would you go for EndoPredict, or would you say, okay, this is luminal A tumor from the classic parameters, I will go for oncoplastic, or would you go for EndoPredict?
So in a luminal A tumor, I'm not entirely sure whether EndoPredict is really great, because it's pretty clear with these patients, it's not going to do great things, right, with neoadjuvant chemo. I think it's rather in the patients that look like luminal B tumors. This is really what we saw in our own data. You have these patients that they're ER positive, but they have a G2 and they have a Ki67 that is 30%, and they have some lymph nodes. So you're kind of, oh, this could be much more aggressive. Maybe she needs chemotherapy. And it is in those patients where you can identify a low molecular score, and you can see, whoa, it's very unlikely she will have a good tumor shrinkage. So I think this is really the strength. What you can see in the paper is that the patients that were chosen for neoadjuvant chemotherapy were purely luminal B and fairly aggressive tumor types there. And we were still able to identify some low risk EPs. And I think that's what's interesting in the study. The neoendocrine part, it's a small cohort, it's intellectually interesting, but personally, I'm not doing a lot of neoendocrine, and probably some of the British people really need to comment on that because I don't have enough clinical experience on it.
Peter, I have another question for you now. Again, very, very surgical. Well, first of all, let me tell you that we had as much as 115 participants today. And if you want to keep track on the activities of our association, please follow us on the UBreast page of LinkedIn. And by the way, we just sent the link. Well, we already sent the link of the paper of the Lucerne Toolbox, Peter. So, but the question is about what do you think is the impact of biology in the application of the Z11 criteria? So
there's a very clear guidance on that. We we call these the post C11 questions. And during the St. Gallen consensus, and Giuseppe is going to start laughing in a minute now, we had 1 million questions trying to adapt the C11 to the mastectomy patients, to the aggressive biology patients, to the patients with more lymph nodes. And looking back at that consensus, speaking from the St. Gallen consensus panel, and this was very similar for the Lucerne toolbox, people don't care about biology on that. They consequently implement the C11 criteria, and they do not care if it's a HER2 positive or a triple negative breast cancer. And it really goes back to that Monica Morrow type of paradigm. You can have very aggressive biology, and you have some surgeons that are willing to do very proper axillas on that, and it's not going to help your patient. It just isn't.
Sure.
So I think we can be fairly clear on that.
Yeah.
Probably
That's
Giuseppe knows by
important.
heart, but I think the consensus was like 85% on that or something like that.
Okay, I agree entirely. I think this is
absolutely
according to our guidelines.
Absolutely. And I have a question for Giuseppe concerning the ADAPT trial. So we've learned that patients with an intermediate recurrence score and have a dynamic change and drop in the Ki-67, basically they do well with endocrine treatment alone. But what do you think is the most important driver between these two factors? It's the recurrence score at the beginning or the drop in the Ki-67 to be the most important one?
You know, the hypothesis is here that if you have a response to endocrine therapy, for sure you have an endocrine sensitive disease, so you will have less opportunity to recur. The major limitation is that finally you don't have a so long follow-up to conclude this. So I would like to see longer follow-up data to confirm that endocrine therapy alone is enough. And the second point is that you did not change your surgery, of course, according to the cell cycle control, because patients who should receive a breast conservative surgery will do this, and other patients who should receive a total mastectomy will do exactly the same choice. So the trial, I believe, is important because you can drive the decision post-surgery according to the biology and let's say a window of opportunity treatment before surgery. So this is really very provocative. And you know, sometimes we give to ER-positive disease 6 months of chemotherapy, and we don't know if this is useful or not to impact on the outcome. So if you have a CT2 and 1, you usually give 6 months of chemotherapy, and maybe is enough to do a short-term endocrine therapy and to test with recurrence score to select the patient for endocrine therapy alone. You know that Michael Lynch will not agree on this, but I believe this is provocative because we should think about a larger trial with this approach.
Thank you.
Okay, thank you very much. I think there are not too many questions now in the FNA, and I would like, since we are approaching the 7 p.m. margin, I would like to repeat the questions that we had in the beginning, because we started with a question, do you use pre-operative short-term endocrine treatment? And we had a very intensive and high-quality discussion now on the impact of tumor biology, including pre-operative endocrine treatment. So we would like to know, and Julia, could you again present the question? Now, after the presentations, the very outstanding presentations and the very important discussion, do you think short-term endocrine treatment should be used prior to upfront surgery and early ER-positive, HER2-negative breast cancer patients? So please give your voting now, and you have 15 seconds to vote.
10 more seconds. 5, 4, 3, 2, 1. Here we are.
Whoa. Wow. So congratulations to the speakers.
No, I personally
really-
disagree, but in any case, okay, you are a surgeon, so I can understand.
Well, this is a really important effect of your really excellent presentations. So just to give you, just to repeat, we had in the beginning 6%.
I remember, yes.
Okay, so we went up to 74%. So I think this is really extraordinary.
So can you invite me to the next EU breast meeting? Because I would like to attend.
Certainly. We are honored to invite you, Giuseppe.
Okay, thanks a lot.
Pleasure.
So I think we have to come to an end. We have almost 7 p.m. If there are any further questions from the audience, please don't hesitate to contact our speakers or to contact Oreste or me. I really want to thank all participants. I want to thank our fantastic speakers, Giuseppe and Peter. I think you did an extraordinary job. I also want to thank the people who supported this meeting, Sarah Goldman, our network coordinator, or Julia, who did a perfect job to organize the meeting, from Polytech, or Mario as well. We want to thank the supporters, Myriad Company. And I want to invite all of you attendants to join our association if you want to participate. Please follow us on our website, www.eubreast.com. Please note that we are a non-profit organization, and it is our aim to connect breast surgical scientists throughout the world and to improve the cooperation. And I think this was our second webinar, and I think it was really very successful, and it's a real fun to work together. So it's not only, it is scientific progress, but it's also fun to collaborate with you in this really fantastic community. So I want to thank you very much, and bye-bye, and have a very nice evening.
Bye-bye.
Bye-bye.
Thanks a lot for
Good evening, everyone.
Bye-bye. Ciao.
Bye. Thank you.